So, good afternoon, everybody. So, I will talk briefly about our strategy in prevention of infection in TKA patients. So, I will give you introduction and show you some images that we have obtained from infection lab in Basel in Switzerland, and I will show you something that we want to implement in our daily practice that has roots in international consensus about management of surgical site infections, and it addresses perioperative skin preparation and operative environment, as well as implementation of incised draping and hypothermia. So it starts with this thesis, and we need implant as well as bacteria and host in order to have PJI. We know that more than 50% of all PJIs come from skin, and that most common bacteria like S. aureus and epidermidis are in more than 50% responsible for our PJIs. How does it start? It starts with the race for the surface. The moment we put our implant in the patient, then the bacteria start to race and they tend to colonize the surface. And this is how it looks in a lab environment. These are scanning electron microscope images, and on the left side you see normal bacteria, the weakest of them all, S. epidermidis, that is able to produce biofilm that has polysaccharide intercellular adhesin, and this is how it looks after 16 hours at the surface of our implant. What we tend to do in our daily practice, we tend to minimize our incision, and we, in spite of implementing all precautions and all measures, there are good studies that have shown that after 20 minutes after opening of the skin of the patients, all sterile surfaces in operating theater are colonized with bacteria from the skin, in spite of everything what we do. We know also from profilometric studies that the greater the surface of the implant is, the easier bacteria colonize and find their way to find places like you see here on the right side to aggregate and to start colonizing our implants. So how can we prevent periprosthetic joint infection? We know all the measures, and in our daily practice, we try to implement what we've learned from consensus meeting organized in Philadelphia and led by Torsten Gerke and Javad Parvizi. So I will show you some of the things that we tend to address in our daily practice, like perioperative skin preparation, and what we've learned from this, and then we try to implement it, that the role for preoperative skin cleansing with an antiseptic is, according to all the delegates that have gathered at the meeting, 90%, and we advised all our colleagues and the team to do preoperative cleansing with chlorhexidine gluconate, and I will show you at the end of this section that we can use also another antiseptic to do so. So what type and when should preoperative skin cleansing be implemented? And it should be at least one night prior to elective arthroplasty, and the consensus rate was 85% on the meeting. When we come to skin preparation in terms of hair removal, then consensus was 92% in terms of, or in favor of hair clipping. And when should it be done? It is advised to be as close to the time of the surgical procedure as possible, and the consensus was set to 94% of all the delegates at the meeting. So there are more than several studies that show that preventing surgical site infection is also related to body washing, especially in those patients who are nasal carriers of S. aureus. And if we do general decolonization of the skin and nasal mucosis, then it is shown that it reduces risk of PJI for 60%. There are also very good data for the agent that we use for antiseptic, that we use octanidynes, and group, and a colleague of mine, Andrej Trampuš, has shown on a very big number of patients that they have reduced the risk of infection by using octanidynes. So we tend to use it more and more in terms of preparation, and in private practice we are able to implement octanidyne preparation for 5 days prior to TKAs. And you can see that if you use this sort of prophylactic approach, then you are able to reduce and lessen the number of CFUs present on the skin in all cases here shown, and it's much better than selective decolonization with antibiotics. So what can we do in our operative environment in order to prevent PJIs? So one of the key points of the consensus meeting was to address normothermia during during the surgery, and it has been recognized as a significant factor that can prevent infection, and the consensus was set to 92%. And the role of incised draping was, the rate was a little bit lower in terms of consensus, and it was set at 89%. What type of draping should be used in operating theater? The most important thing is to, oh, that's mine. Oh, I thought, sorry. The draping, the most important thing is to use impervious drapes, and that's the message from the consensus meeting. So let's see a little bit how does hypothermia evolve during time that patients spend in operating theater. So up to the start of anesthesia, and these are dates. These are data for total knee arthroplasty patients. Up to the time of incision, they spend already a lot of time in hypothermia, and altogether duration of hypothermia was 44 minutes for those patients with TKA. So we need to respect hypothermia, and we need to influence those factors. These are factors that are modifiable, and we can address ambient room temperature, and we can shorten the time from entrance into the operating theater to incision. So these are basically essentially factors that can be influenced, and we should keep our patients warm in the pre-op area. So to conclude, perioperative hypothermia is a common in TKA, and the greatest decrease in core body temperature came between preoperative area and surgical incision, and we can modify these factors. Thank you.
Thank you very much.